Hello everybody, I'm here to present a retrospective short review study looking at the association between thionamide and pancreatitis. Thionamides are widely used to treat hyperthyroidism. In 2019, the EMA issued warnings citing acute pancreatitis as a rare but serious potential adverse event. This is based on findings from case report and cohort study that were done outside the United States. The risk of acute pancreatitis associated with thionamide remains uncertain. In this study, we identified patients with concurrent use of methimazole or PTU with a diagnosis of acute or chronic pancreatitis to evaluate the risk factor and assess potential causality through individual case review. We use our database at the University of Florida, and we identify subjects who met inclusion and exclusion criteria via our database and I2B2 query. We review individual patient clinical records, and we use a predefined causality assessment framework to identify the potential etiology of pancreatitis. So our inclusion criteria include patients seen at UF Health in Gainesville, Florida. The patient has to be at least 18 years of age, receive a prescription for methimazole or PTU. The study period were from January 2011 to April 15, 2025. The patient had to have a diagnosis of either acute pancreatitis or chronic pancreatitis. We ended up with a 37 subject. We then individually chart review and confirmed 34 subjects have pancreatitis, 20 of them have acute pancreatitis, and 14 had chronic pancreatitis. All of the cases were methimazole user. Let's take a look at Table 1, which describes the patient characteristic. Majority of the patients are around 67 years of age. Most were female. We have a very diverse patient population. 55% are white, 42% are black, and 3% Hispanic. The average BMI is around 25 kilograms per meter square. Majority of the diagnosis were Graves' disease. In the chronic group, Graves' disease and multinodular goiter were the common diagnosis. The average methimazole dose were around 10 milligrams. The lipase in the acute pancreatitis group is higher than those in chronic group, which makes sense. And the TSH among the two groups were suppressed. Table 2 helps us understand more about the causality assessment. It is certain to say that a medication causes an event if the medication intake occurs prior to the event, and that nothing else can explain the event. Other drugs were ruled out, and when you withdraw the drugs, the pancreatitis resolves, or when you introduce the medication again through the rechallenge, then the event occurs again. You recall it probability when those criteria met, but rechallenge is not required. We can say that a drug can possibly lead to pancreatitis if the drug's intake occur before the events. However, it's possible that other drugs can cause the pancreatitis too. For example, the patient can also take valproic acid, sitagliptin, azathioprine, or many other drugs that could potentially cause pancreatitis. and we don't have enough information about drug withdrawal, and hence the relationship is not certain or probable, but is possible. When the event occurs before the drug intake, it is very unlikely that the drug lead to the event, and hence the relationship would be described as unlikely. So we have 34 patients identified as eligible. 20 of them have acute pancreatitis and 14 of them with chronic pancreatitis. The 14 patients with chronic pancreatitis were identified as having chronic pancreatitis before the use of metimazole. Therefore, the relationship that metimazole lead to chronic pancreatitis is unlikely. Among the 20 patients with acute pancreatitis, 10 cases were excluded because pancreatitis occurred before the use of metimazole. Among the remaining 10, the duration of metimazole use before pancreatitis ranged from 6 months to 22 years. Average medians were 10 years. We have 9 patients with identifiable alternative causes for acute pancreatitis, and this including gallstone, alcoholic, high triglyceride level, ERCP, or structural causes. We have 1 patient that possibly could be caused by pancreatitis, but maybe not. And let's look into that case. It was about a 77-year-old female with Graves' disease, and she developed acute pancreatitis after 2 years of use. Her original dose of metimazole was 15 milligrams per day, and eventually down to 5 milligrams every other day. 2 years later, she presented to the ED with severe pancreatitis. Her lipase were in 1,000 with a positive CT imaging. Further workup showed normal lipid panel, normal A1C. Other imaging, including right upper quadrant ultrasound, did not show any gallstone. She has no history of alcohol or tobacco use. Unfortunately, her pancreatitis was so severe that she developed shock, was on multiple pressor, and eventually passed away. In this case, metimazole-induced pancreatitis, although it seemed unlikely because of the time frame of 2 years, however, we cannot rule it out completely, and therefore, we put this case as a possibility. Overall, to summarize, the current literature supports that the risk of pancreatitis occurs mainly within 3 months of use. Our analysis show that the risk of metimazole-induced pancreatitis is very low, with the incidence of possibly 1 case out of 3,971 subjects. That's equivalent to about 1.8 in 100,000 per year in our cohort. The cases that we describe have occurred 2 years after metimazole use. However, we cannot rule it out completely, and this finding overall highlight the diagnostic challenges in attributing causality and emphasize the need for a comprehensive evaluation. Thank you so much for listening.